Today, we'll report on news from the 2015 World Congress on Gastrointestinal Cancer. All this and more starts right now on UncLive News Network. Hello and welcome. I'm Laura Jones. Last week, physicians from around the world attended the 17th ESMO World Congress on Gastrointestinal Cancer in Barcelona. In a late-breaking abstract presented by Fortunato Cirdello, patients with relapsed metastatic colorectal cancer experienced a 44% reduction in the risk of further progression after second-line treatment with cetuximab plus FOLFOX, as long as their tumors were negative for KRAS, NRAS, BRAF, and PIK3CA mutations. In the randomized Phase 2 study, quadruple wild-type patients who continued cetuximab even after progressing on cetuximab plus FOLFIRI had longer progression-free survival than with chemotherapy alone. The difference of 6.9 versus 5.3 months was statistically significant. Response rate and overall survival were also improved, said Cirdello. The results suggested that continuing anti-EGFR treatment while switching the chemotherapy backbone in second line is feasible and deserves further exploration in a larger trial. Cirdello added a word of caution concerning the detrimental effects of cetuximab following progression of tumors harboring mutations in any of the 4 genes. Next from the meeting, an analysis looking at 2 randomized Phase 3 trials of regorafenib used as salvage therapy for metastatic colorectal cancer confirmed the overall survival benefits of the oral multi-kinase inhibitor for both Asian and non-Asian patients. According to Axel Grothe from the Mayo Clinic in Rochester, the CORRECT trial enrolled mostly mixed Caucasian patients, almost half of whom had received 3 or more prior therapies. Less than half the patients had ECOG performance status of 0 or 1. 100% already received a biologic. The CONCUR trial enrolled Asian patients, 38% of whom have received 3 or more previous therapies for metastatic disease. Approximately 3/4 were ECOG performance status 1, and 41% had no prior biologic therapy. Less pretreatment, especially with biologic agents, may explain the larger gain of overall survival observed in the CONCUR trial compared with the CORRECT trial, noted Dirk Arnold, who discussed the data. Grade 3 or higher treatment-related toxicities were similar in both studies. Importantly, both studies looked at regorafenib 160 mg dosage. A poll of the audience showed that the frequent dose modifications based on toxicity concerns are the norm with this agent. In another analysis, this time looking at the expanded access program data for regorafenib, Eric Van Cutsem reported that experience in more than 2,800 patients in the real-world setting of previously treated metastatic colorectal cancer confirmed those of the Phase 3 CORRECT trial. In this study, regorafenib demonstrated a median progression-free survival of 2.0 months compared with 1.7 months for placebo. Regorafenib reduced the risk of progression by 51%. Adverse events were similar between the studies. The estimated PFS was similar regardless of KRAS mutation status, said Van Cutsem. Regorafenib-related adverse events leading to treatment discontinuation occurred in 9% of patients, while dose adjustment because of side effects was reported in 60%. The most common treatment-related grade 3 or higher toxicities were hypertension, hand-foot skin reaction, fatigue, diarrhea, and hypophosphatemia. One non-fatal case of severe drug-induced liver injury was reported. We need to establish clear guidelines on the management of adverse events to make taking the drug more tolerable, commented Van Cutsem. These findings add to our knowledge of how to select patients and how to manage toxicities. In another study of metastatic colorectal cancer, patients with the lowest body mass index had the shortest overall survival when treated with bevacizumab. The study looked at overall survival and progression-free survival across 4 large prospective U.S. trials, including more than 6,000 patients treated with first-line bevacizumab. Those with a BMI of less than 25 had significantly shorter survival than patients in the higher BMI categories. Progression-free survival was comparable across all groups. Lead study author Yusuf Zafar hypothesized that the pattern may be related to treatment-related cachexia, which is in and of itself a poor prognostic indicator. Lower weight patients may have poorer tolerance to therapy and therefore receive fewer subsequent lines. Further research is needed to better understand the clinical implications of BMI as a prognostic factor, as well as a relationship between cachexia and poor outcomes in metastatic colorectal cancer. Last, a phase 3 study looking at adding an NK1 antagonist to a 5-HT3 receptor antagonist and dexamethasone for prevention of nausea and vomiting induced by oxaliplatin showed promising results in Japanese patients with colorectal cancer. Lead author Junichi Nishimura presented the data from a randomized phase 3 study comparing a 5-HT3 receptor antagonist and dexamethasone versus aprepitant or fosaprepitant added to the combination. Aprepitant-based therapy was more effective for both overall and delayed emetic control, showing more than a 95% rate of nausea and vomiting prevention. The effect was particularly pronounced in women. Although the results have important implications, they were in contrast to those of a previous trial. Thus, more data are needed to make a final determination. And that'll do it for today. Thanks so much for joining us on OncLive News Network. I'm Laura Jones. We'll see you next time.